Hello, let's go through the anatomy of the liver. Okay, so the liver is contained within a very strong capsule that's made of collagen, and it has a lot of functions, basically, but most of the processes are exothermic, so they're going to release heat, and it's found on the upper border of the fourth intercostal on the right, and about like the fifth intercostal on the left. And the lower border is going to be like along like the 10th up to the along this along the 7th, like from 10 up to 7, or the 6th intercostal space. In the mid axillary line you can see a little bit better, you can see here. So the liver is like from about 6, and then the lung is about 8. The pleura will like end at the 10th rib. You can see here in the back, the liver is quite large. So there are the relations to the diaphragm superiorly, viscerally. There's going to be the right triangular ligament or the right colic flexure. There's going to be the stomach resting on it, the right kidney, the suprarenal gland, the duodenum, and the gallbladder. And at the infrasternal angle, the inferior border is going to be adjacent to the anterior abdominal wall, and you can actually percuss it. In a normal person, you can't hear it, but if it's if this person has hepatomegaly, you can hear like a dull thud. The ligaments will run with the right kidney, the right colic flexure, and the duodenum and the pancreas, and it all kind of binds it all in place. The most important support, however, are going to be the inferior vena cava and the right hepatic artery that kind of like holds it in place. And it's important for the static processes, which is the positive intra-abdominal pressure, and the movement of the diaphragm will like keep the liver in place. So here's the right triangular ligament. This is the anterior, or this is the posterior view of the liver. So here is the inferior vena cava, gallbladder right here. Right triangular ligament, coronary ligament, falciform kind of reaches forward here. And the left triangular ligament. So this will bind to the stomach and the pancreas in the back. Okay, so let's go through the ligament some more. Falciform ligament right here. Right here is this is like you looking down, like superiorly down onto the liver. So this is your internal vena cava. Falciform will attach the liver to the anterior wall. The corona will be the falciform when it splits, and that connects the liver to the diaphragm. And the right and left triangular will blend and bind the liver to the peritoneum. The teres ligament is going to be just a remnant of the umbilical vein. The hepatorenal and the lesser omentum is going to bind you via the hepatogastric and the hepatoduodenal ligament. And then the venous ligament is going to be an obliterated venous ligamentum from embryology. So as you can see here, this is where it binds. If this is like the liver being lifted up, usually it would like rest on like directly onto the stomach. This is the superior coronal ligament binding things to the diaphragm. Falciform ligament to the wall. So kind of think of this in 3D. Okay, so there's just like the right lobe and the left lobe. Right is huge, left is small, and in the back is going to be the caudate lobe. The teres ligament and the venous ligament is going to lie on the left vertical ligament. And the right vertical sulcus is where the gallbladder and the internal vena cava kind of like is snug in this area. And then the quadrate lobe will have the portal vein behind it, and it's going to be bounded by the gallbladder. So you can see here the quadrate lobe. And then the caudate lobe is going to lie beside the porta hepatis and like kind of behind the internal vena cava above the gallbladder. So the lobe has the porta hepatis fissure, which allows the common hepatic duct, the hepatic artery, the portal vein, the nerves and the lymphatics to go in. And then the Cantley's fissure is going to be the main portal fissure, and that runs like from the gallbladder to the internal vena cava through the caudate lobe, and that contains the middle hepatic vein. The left portal fissure is going to run from the midpoint of the inferior edge to the confluence of the right, left, and middle hepatic vein. So it like kind of runs like or diagonally, and that will contain the left hepatic vein. The right portal fissure is, it kind of depends. It usually runs like diagonally from the right lobe to the termination of the hepatic vein, but sometimes it can go like squiggly here, go up here, but in all of them they contain the right hepatic vein. So the umbilical fissure will contain the major branch of the left hepatic vein, and the umbilical portion of the left portal vein is going to like give us the direct access right into the left portal vein. So here's the portal vein right here. Here's the hepatic artery. Okay, so the blood supply is really important because there's like two. The hepatic artery and the portal vein will carry blood to the liver, and most of the blood will come from the portal vein to be processed. And it goes straight from the GI tract up into the, well, not really, this is just a diagram, it doesn't go straight up, but it goes through the hepatic portal vein into the liver. And then inside the liver, it divides into the right and left terminal branches. And then the hepatic artery is it's going to be the branch of the celiac artery, and that actually supplies the liver with blood for the liver to be like, used, not just to process. And then inside it's going to be anastomosing, and it goes through the liver sinusoids in order to do that. And then the central veins will drain into the right, the middle, and the left hepatic veins, and then that goes right into the internal vena cava. So like right into here. So the portal vein comes from the intestines and the splenic vein, and then is processed. So the liver is supplied kind of like segmentally, and most people use the Coinard's classification, and that's just kind of based on the blood supply and the venous drainage. And in this classification there's going to be 8 separate sections, and the caudate is going to belong to the right and the left lobe, so it's kind of split, and the quadrate is going to belong only to the left lobe. So the right hepatic vein will separate the right lobe into the anterior and the posterior sections, and the middle vein will divide everything into like the right and left lobes, and then the left hepatic vein will divide the left lobe into the medial and the lateral parts. And then the portal vein is going to divide the liver into like upper and lower segments. So all this is separated so the segmental resections can minimize the blood loss and not damage like nearby segments. So if you need to get rid of like segment number 7, so topmost part of your right lobe, you know that you have to keep in mind of the right hepatic vein. And so the histology, blood enters the liver lobule through the hepatic triads, goes through the sinusoids, leaves the lobule through the central vein will converge, and then transport the venous blood from the liver through the ret mirabile venosum. Lymphatics will drain basically all into like the portal vein. The posterior of the liver surface will drain into the diaphragmatic, so it goes up into the diaphragm lymph nodes, and then posterior into the mediastinal posterior nodes. The lymph from the coronary and triangular ligament will go right into the thoracic duct, which is on the left side. And remember, the thoracic duct drains like 75% of the body. And then the inferior inferior, anterior, and superior surfaces will drain into the hepatic nodes, while the right superior surface will just drain into the celiac node. So it kind of like just flows upwards, except for like the left nodes, and that will just kind of go down, but it drains directly into the thoracic duct. So the hepatic plexus is going to be made out of the sympathetic nerve fibers of the celiac plexus, along with the preganglionic parasympathetic fibers from the anterior and posterior vagal trunks. So dual innervation right here. Gleason's capsule is going to be innervated by the somatic lower intercostal nerves, and that is like the somatic sympathetic portion. It's going to be poorly localized pain if it comes from the parenchyma. So it just kind of feel like diffuse, dull, deep pain. But pain from the capsule is very well localized. Neat thing about the liver is that it can regenerate quite well if you're healthy. The only danger is like, massive hemorrhage. You're not going to die from like parts of your liver missing, but you will die if parts of it is missing and the vessels have not been ligated. So in order to get a liver biopsy, you want to go through ribs 9 and 10, make sure the patient has let out all of the air in their lungs in order to make the lung pleura ascend. Jab a large bore needle in, take a biopsy out, and you're good to go. Okay, so Budd-Chiari syndrome. Look at this. This is caput medusae. This is the distension of the esophageal veins, like up here, along with a lot of other like varices of the abdomen. And this is a rare condition where the obstruction of hepatic venous outflow is due to some kind of like occlusion, and it hypertrophies the accessory inferior or middle right hepatic vein. It's also seen in like hepatomegaly, of course, ascites, and it's really characterized by like abdominal pain, along with like all this ascites. The causes can be idiopathic, or there's of course diseases such as liver failure and cirrhotic liver, and oral contraceptives for women will cause it too. And it's also secondary to conditions associated with like hypercoagulability, of course, because that can cause a thrombotic occlusion. Usually the culprit is polycythemia vera. Cirrhosis of the liver is going to be the progressive necrosis of hepatocytes and the growth of the fibro tissues and the deposition of fat, replacing your healthy parenchyma, caused by alcohol abuse, hepatitis from infectious or viral sources, and copper accumulation. And of course, it messes with the liver, messes with the metabolism, and detoxification. So the TIP surgery is going to be some kind of portosystemic shunt, and it's done to relieve the portal hypertension. This is a pretty risky surgery, and it doesn't actually fix the disease. It kind of like gives you an extension on your life, so you can wait a little bit longer in order to get the liver transplant. Without the transplant, it will lead to the encephalopathy because there's not going to be any liver to detox the blood, and the blood, since it's all connected with the portosystemic system now, so all of the blood from the GI tract is not going to be filtered. It goes straight into the systemic system. It goes straight to the brain, and it causes deposition of all the bad stuff and leads to encephalopathy. So the most common version is not to get the entire liver transplant. You're just gonna get a partial liver transplant, because remember, the segmentation of the liver is just easy, because if you know which segment has been removed, you can connect the hepatic arteries, ducts, and veins. In a hepatic transection, the liver has to resect the liver parenchyma slightly to the side of the canthalized fissure to avoid the trunks, because that will be fatal for the patient. Another thing to take note is the right hepatic artery in some population can cross right in front of the hepatic duct, and that can be prone to injury. The most common anatomic variant is the replaced or accessory artery that originates from the left gastric artery or the superior mesenteric artery. So there's just like an extra vessel that you need to pay attention to. So that's it for now. Thank you for your attention and good luck studying.